أهلا بيكم في ذا لاونج. النهارده حلقتنا هنتكلم فيها عن الجهاز الهضمي، صحة الجهاز الهضمي وإيه الأمراض الصحية والمشاكل الصحية اللي ممكن تصيب الجهاز الهضمي وإيه المشاكل أو الأمراض اللي ممكن تصيب القولون. Do you know that the colon cancer is considered the third cancer risk after breast and prostate? What we should do to protect ourselves and our colon as well. So that's why I encourage you to join us this episode, and we in the beginning would like to welcome our guest, Dr. Daniel. People would like to know more about it. I have many questions about it, but that's in the beginning. I want to ask you, Dr. Daniel, what are the main parts of the bowel tract and their main function? To know the function first.
Okay, so essentially the bowel starts at the mouth, and when we eat food, it goes into the mouth and then to the pharynx, and then we swallow it. And it goes down what's called the esophagus, which is just a tube that goes from the back of the throat down to the stomach. It's about 25 centimeters in length, and all it does is basically transport the food into the stomach. When the food goes into the stomach, we have a lot of acid in there, and it starts to break down the food. And then it sits there for about 40-45 minutes, and then it gets pushed into the small bowel. So the first part of the small bowel is called the duodenum, and in the duodenum we have there's four parts of the duodenum, and this is where the partly broken down food meets some of the secretions from the gallbladder and from the pancreas, and it starts to digest the food as it slowly moves through the rest of the small bowel. The small bowel ranges in length from anywhere from 3 meters to 6 meters in length, and as the food goes through that small bowel, a lot of the nutrients get absorbed in that section. And so by the time it gets to the end of the small bowel, it then enters the large bowel, the colon. And it's in liquid form at this stage. And as it enters the colon, it slowly moves its way through the colon, and the colon largely absorbs water. So by the time it gets to the end of the colon, and the colon's about 1.5 meters long, it becomes obviously solid, and then it gets stored in the last part of the large bowel, which is the sigmoid colon and the rectum. And as that slowly builds up, we start to get the urge to go to the toilet, and we pass the waste. So that's basically a rough summary of how the food goes from the mouth to the
journey
bowel.
from the food. And throughout this journey, the body can benefit from the natural, the goods in the food.
That's right.
So what's good? So anything happen to the bowel system that can affect our absorbing of the nutrients?
So obviously, we absorb nutrients in different parts of our bowel. So as we said before, the small bowel absorbs most of the actual nutrition that's in the food. And so, for example, the end of the small bowel is largely involved in absorbing iron. So when we remove that part, sometimes people can develop difficulties absorbing iron, which leads to things like anemia. On average, though, as long as we have a certain amount of small bowel, we have enough to be able to absorb enough nutrition to keep us alive. And that's usually about 1 meter. So less than 1 meter, we find that people aren't able to get enough nutrition absorbed through the bowel. So bear in mind, we said there's about 3 to 6 meters of small bowel. So it's usually in very extreme, really sick patients or patients who have certain diseases that we end up in a situation where we've removed so much bowel that they then have to have their nutrition given through the vein, through a drip, rather than orally. But that's pretty rare. And then, like we said, the large bowel absorbs mainly water, but there are many situations where we need to remove most or all of the large bowel, and the body is incredibly good at adapting. And so what happens is the small bowel will do the job of the large bowel. So you can live without a colon, but you do need a certain amount of small bowel to be able to live.
Okay, Dr. Simon, there is rectal bleeding seems very common. We hear about it. Is it something to be considered about, or does the rectal bleeding require the investigation? How can we do more investigation for the rectal bleeding?
Yeah, well, I might let Danny answer more about rectal bleeding, but look, I mean, it's an incredibly common symptom. I think nearly everybody at some point will have some rectal bleeding, and that can be, simply on the paper and bright, and that's commonly due to a local cause like internal hemorrhoids, which I guess are swollen veins on the inside of the anus, or from cuts of the canal called fissures. But sometimes it can be a more serious problem. Okay, and so it's something always worth talking about, with your local doctor, because sometimes bleeding is the sign of cancers, of polyps, or it can be sign of inflammation in the bowel. So while it's a very common symptom, it does need to be looked into because of some of the more serious causes. Sorry, Danny, would you?
Yeah, do you want to add for it or?
No, I agree completely. I think what we often say to the patients is the bleeding itself is not necessarily dangerous. It's more about what the cause of the bleeding is. And often the nature of the bleeding will give us an idea of what part of the gastrointestinal system it's coming from. So if the blood that's being passed is pitch black, then it's usually what we call melena and coming from the stomach, because when the blood mixes with the acid, it becomes black. So that gives us an idea that the blood is coming from in the stomach. Okay. If it's maroon in colour and sort of darker in colour, and especially if it's mixed in with the stools, then it's coming from higher up in the bowel. Most commonly, though, it's bright red, it's painless, that follows emotion, and that's usually what we call outlet bleeding or coming from the anus, and is most commonly, by far the most common cause, is hemorrhoids. And hemorrhoids in no way are dangerous. Hemorrhoids don't turn into cancer. Hemorrhoids rarely require people to be put in hospital. In fact, I can only think of one case in my career where I've had to put a patient in hospital for hemorrhoids. But they do cause a lot of distress, because sometimes, because it's right at the bottom, the blood can sometimes be so dramatic it splashes all over the toilet bowl and looks almost like a crime scene. So people panic and come rushing to either the hospital or to their doctor. But once we've investigated it, which we'll talk about a little bit later, and we know what the cause of the bleeding is, if there's a bit of bleeding every now and then, once you know that it's nothing too dangerous, then usually it's just about lifestyle changes rather than needing surgical intervention or anything like
If
that.
it's light bleeding, what advice can you give to the patient? Are they going to go straight to the doctor, or some patient maybe they ignore it or feel that's something that comes just and goes? Dr. Simon, do you want to?
Yeah, no, look, I think if anybody who's had bleeding should talk about it at least with their GP, and if it's something that's ongoing or something that's happened repeatedly, at least once they should have that looked at and investigated, just because you can never be sure. And I think it's important, in terms of the risk of the patient. So somebody very young having the odd bit of bleeding is different to somebody after the age of 50 or 60 having bleeding for the first time. But it's always worth discussing that with a doctor.
I want to let the viewer knows that we are on the Lounge at the moment, and the Lounge app is Slido is working at the moment, so we encourage everyone to join us our episode and send us your question, and our doctor is going to answer all these questions for you. Dr. Simon, how we can talk about the colon cancer, because many people maybe knows colon and just have a scare from the colon cancer, and you need to know more about it and what are the causes at the beginning, if we know what's the causes of cancer.
Yeah, look, I think like you said in the introduction, Maggie, it is one of the commonest cancer, and actually if we exclude skin cancer, actually the second commonest cause of overall cancer in all men and women. In fact, 1 in 11 men will develop a bowel cancer by the age of 85 in Australia, and 1 in 16 women will develop a bowel cancer.
So it's more common for women,
it's
men?
More common in men. It's definitely more common in men. Look, your question about what is the cause, we know there are a number of different factors that contribute. So part of it is inherited risk and the genetics from your parents or other relatives. So the family history is very important. There are some other known risk factors. So if people have had a colonoscopy for whatever reason, so a telescope examination of the colon, and there are polyps in the bowel. So we know polyps are the precursors of bowel cancers. So it always starts off as this benign, fleshy growth in the bowel that can over time grow and become bigger and turn into a cancer. So if you've had polyps before, that increases the risk. And then we know that there are other risk factors that are interesting. So people who have certain conditions of the bowel, like inflammatory bowel diseases. So you may know of people who have Crohn's disease or ulcerative colitis, which are autoimmune conditions where the body's immune system attacks the bowel and causes ulcers. That increases the risk. There's a lot of interest in terms of diet and lifestyle. So having excessive red meat, too much red meat, particularly processed meat. So, your hams, your mortadellas,
all the cold meats,
all the cold meats, also increase the risk. Too much alcohol in the diet, and there's also interest looking at, people having not enough fibre in the diet. So less fibre in the diet may also, increase the risk. But there's still a lot of unknowns about the cause. Of bowel cancer, but it's incredibly common, and the thing about bowel cancer is that because it's so treatable, detected early, it's important to be aware of, and why we think it's a really good topic to present today on the lounge.
That's very good. As long as you said that's the treatable, so we need to know what's the symptoms, so everyone can having any of these symptoms can go and check it. Firstly, Dr. Daniel, if you can speak about the symptoms of colon cancer.
So I guess our aim really is to, prevent bowel cancer if we can, and secondly, detect it before symptoms have developed. There are several risk factors. By far the biggest risk factor for people who don't have hereditary or inherited causes of bowel cancer is getting older. So we tend to see bowel cancer more in older patients than we do in younger patients. So when Simon was saying before, bleeding in a 20-year-old is much more different to bleeding in a 60-year-old, it's because the risk of a 20-year-old developing bowel cancer is, say, 1 in 20,000, whereas the risk of a 60-year-old developing bowel cancer increases to, say, 1 in 500. So as we get older, with most diseases, we are more at risk of it, and bowel cancer is no exception. But if we look at the symptoms that are alarming, that send off, which will make us look worried if we're sitting in the office opposite you, if you tell us. So things like, depending on where in the bowel it is. So for example, if it's right at the beginning of the large bowel, so right when the stool is still liquid, if those tumours in what we call the right colon, which is near the appendix and that area, when they tend to bleed and bleed very slowly. So what we see is patients becoming anemic, a drop in their blood count. So if we see a male who is anemic, that would make us worried. Or a woman who's been through menopause and therefore has no other reason to be anemic, that also would make us worry, and we'd want to do a colonoscopy in that situation. As you sort of go through, the other symptoms that you worry about are things like a change in bowel habit. So patients often will say, I go to the toilet once every 3 days and my husband will go to the toilet every day. Why am I abnormal? And we feel that going to the toilet every day is normal. Well, we're all different. And so what we worry about is, has your bowel habit changed? Did you go from going to the toilet once every 3 days to 3 times a day? That would be more concerning than you going to the toilet once every 3 days, because everybody's different. There is no normal as far as how often you should go to the toilet.
Some people have a different idea, or maybe wrong. Or
so everybody feels that I have to go to the toilet
every
once
day.
a day.
It's healthy.
But really, we're all designed differently. And I have some patients that go to the toilet 3 times a day. And I have some patients who, believe it or not, will go to the toilet once a month. So we're all different and we're all normal. But if that changes, that would be alarm bells. So, or if you develop, say, diarrhea that wasn't there before. So any change in how your bowels work. Obviously, things like abdominal discomfort. So you're getting bloated. You're getting a lot of pain. Pain that's like contraction would obviously concern us. weight loss that you can't really
Yeah.
explain if you're losing weight but not dieting, which to many sounds like a good problem to have, but really
Yeah.
would worry us a little bit. And then obviously the bleeding, like blood mixed in with the stools is more concerning than the blood after the motion. But it really, if there's anything that worries you, especially if you're over the age of 50, you should see your doctor, because the cure rate of bowel cancer, when it's detected early, is almost 100%. So this is something that even if you get diagnosed with, as long as you don't leave it till you're almost dead, then this is curable. So if you are worried, I know it's an embarrassing thing to talk to your doctor with, and most people, especially men, don't want to talk to their doctor, but it's really important you go and talk to your doctor, because these conversations are really common. The doctor's not going to look at you and go, "I've never heard of this before." This is a common problem, and we encourage people to talk to
you
them.
talk about a very important point, that how can we detect the colon cancer. Dr. Simon, if we can focus more about this, because it's very important to everyone to know the causes and symptoms and risk factor, and how can we detect it early, because it's very treatable if we detect the colon cancer early. So how can we know?
Yeah, so the test to find and diagnose a colon cancer is a colonoscopy, and so this is a procedure where after having a bowel cleanse, so you've got to drink a bowel preparation which gives you the worst diarrhea you've ever had to clean out the bowel. You come in under an anaesthetic. The doctor will pass a telescope from the back passage all the way around the large bowel, just to where it joins onto the small bowel, the ileum. And so that's a day procedure. The whole procedure takes, usually no more than half an hour.
Is this how to detect the colon cancer?
This is how to diagnose it and find a bowel cancer.
Okay.
And so the procedure itself takes about half an hour, but you're out of action for the day because of the anaesthetic, and you go home the same day.
Yep.
However, not everybody who has any symptoms, needs to have a colonoscopy. But if there are concerning symptoms like what Daniel was saying, iron deficiency, anemia, unexplained weight loss, rectal bleeding, a very strong family history of bowel cancer, then in those cases the test that you need is a colonoscopy. That's different to general screening for somebody who doesn't have any symptoms, somebody who just wants to have a general checkup. Okay.
Yep.
But if you have symptoms and you're getting referred to look and diagnose about them, then the colonoscopy is the procedure. It's a safe procedure. Less than a 1 in 1,000 risk of complications. People are usually back at work the next day.
That's very good. Dr. Daniel would like to know more about the National Bowel Cancer Screening Program, because it's very important to know what's important of it at the moment.
So because this cancer is so common, and we know the cure rates are very good, the government has set up a screening process, and the screening process is a very easy thing to do. Everybody who is a resident of Australia will get, from the age of 50 to the age of 74, will receive a package in the mail every 2 years. And essentially what you do is you send 3 small samples of your bowel motion to the government, and they will test it for blood. And if there's blood in it, it doesn't mean you have cancer. If there's blood in it, and there's lots of reasons you can have blood in it, and cancer is one of the rarer reasons, but if there's no blood in it, then you don't have any of those reasons, including cancer. But if there is blood in it, they recommend you have a colonoscopy. Now, that's from the age of 50 to 74. You can request from your GP, younger than that or older than that, because 74 really isn't that old, to continue that test. So you can get the test kit through, say, Bowel Cancer Australia, or you can get the test kit through your GP, or even your pharmacy will be able to provide that. And the idea there is to, again, detect bowel cancer in people who have no symptoms at all early, like in an early stage, so the cure rate can be very high. Now, having said that, if you have any symptoms, then you should have a colonoscopy. Yep. And if you've had previous polyps, which about a third of people will have. So 1 in 3 people that we do colonoscopies on over the age of 50 will find a polyp. And depending on what that polyp looks like under the microscope, we'll recommend another colonoscopy in either 3 years or 5 years, usually. And so in that situation, there's no point in doing the screening test because regardless of what it shows, you're going to have another colonoscopy in 3 years or 5 years. So it's only in people who haven't had a colonoscopy in the last 5 years and who have zero symptoms at all. And it's always a good idea to talk to your doctor about whether or not you should do this test, but you'll automatically receive it, and it's something we encourage people to do. At the moment, only about a third of people do it. So 2/3 of these kits go on the bin. Well, they go on the bench first, and people go, "I'll get round to it," and then they never get round to it, and they get thrown in the bin next year. So we really do encourage people to do them. It's an easy thing to do, and it's a simple screening test, and it doesn't require needles or probes or anything like that. It's a really simple thing to do, and you do it at home.
It's a very good program. We heard about.
I'll probably just add to that, just to again emphasise, how important is people, actually do the kits that are given to them, in the mail. It's such an easy test to do. But the other thing we get asked, well, look, can't we just go and have a colonoscopy, instead of doing, the fecal occult blood test, and just go straight to a colonoscopy? So we can't do that in Australia now unless there's another reason, to do a colonoscopy. So it's not needed is the first thing. So not everybody needs to have a colonoscopy. But also this has become very regulated, and the regulations are that, you need to have an appropriate risk factor or a symptom or a positive fecal test to then go on to a colonoscopy. But I think your point, Danny, about, whether you can do it earlier or later is very valid, because we're now actually also seeing that colon cancers are starting to be diagnosed earlier, and it is affecting younger people, and certainly there's a move in the States to move to screening. I think it's age 40,
it's
45,
very important to raise
46.
the awareness of doing this screening. Just I want to, because we need to finish the talking about the cancer, colon cancer, we need to know the treatment for it. And do you think it's highly treatment or can treatable, Dr. Connor? Or is there any ways?
So the treatment largely is surgery. But a lot of it depends.
Sorry for interrupting. Just I'm talking about the normal cancer, but is there a different kind of cancer and different treatments?
Yes.
Or do you want to?
So there's the main type of cancer that we see in the bowel is called adenocarcinoma. Now, really, the different types we're talking about is the location in the bowel.
Yep.
So if it's at the beginning of the large bowel, then the treatment usually is to go straight to surgery. But if it's at the end of the large bowel, what we call the rectum, then we often do further testing before to work out whether or not the patient needs chemotherapy and radiotherapy to try and shrink the tumour a little bit and then have their operation. Yeah. So while the type of cancer is the same, it really comes down to the location of it. So, God forbid anyone is diagnosed with bowel cancer, but if you are, the first thing we would do is a CT scan of the chest and the abdomen and the pelvis to look for signs of any spread. Now, if it has spread to any other organs, then it's what's called a stage 4 cancer. And we try to avoid at that stage because it gets a little bit more complicated on how you treat it and how well it will respond to treatment. But the large majority of people, especially if it's diagnosed on that stool test, don't have any sign of spread. So at the time of the diagnosis, what we can tell people whose CT scans are clear is you don't have stage 4 cancer. Once we've done the procedure, once we've done the operation, we've removed the cancer and we remove what's called the lymph nodes, which are the glands where if this cancer is going to spread, it will first spread to that area. So we remove those glands with the cancer and we send that all to the pathologist, all to the lab, and they'll cut it up and look at it under the microscope. And they give us a report that tells us how deep it goes through the bowel. Does it go just through the inside lining of the bowel, or does it go all the way through the muscle to the outside? And they'll give us a report about the lymph nodes. So they'll tell us how many nodes are there and how many, if any, of those nodes have cancer in it. Now, as a rough rule of thumb, if any of those nodes have cancer in it, that makes it a stage 3 cancer, and we would recommend, as long as the patient is healthy, to have what's called adjuvant chemotherapy. So not chemotherapy to treat cancer that we can see. It's almost like chemotherapy, like an insurance policy, to reduce the risk of the cancer coming back. And if that was to happen, usually the chemotherapy is very well tolerated. The biggest concerns people have is, will I lose my hair? And the answer is no, you don't lose your hair. Nowadays we give, usually, most of the time, it's 2 types of chemotherapy combined. One is usually taken as a tablet, and the other one is given as an infusion once every fortnight. So you go to the hospital for a day every 2 weeks, and you have that infusion, and you take the tablets at home. And you have regular blood tests and see your oncologist. But the biggest side effect of that, usually people feel a bit of pins and needles in their hands and feet, but it's usually very well tolerated. What we're really aiming for is a stage 1 or 2 cancer, where it's just in the bowel, in which case then all we need to do is we do routine blood tests, routine scans, just to keep an eye on things, but we don't need to do any further treatment. And the cure rates all over, if you look at what's the overall cure rate or survival rate of bowel cancer, is pretty good. Like it's upwards of 80%, but obviously stage 1 has almost a 100% cure rate. As you get to stage 4, it's sort of about a 50% cure rate. So we're really aiming to diagnose it, if it's present, early. So that's why we will go back to nagging people to do the stool test over and over again.
That's very good. Just so we have to go now for a break, and we're coming back to continue our talk, and we answer some questions. Thank you. See you after the break.
Of us we be, and in these tears we heard a scream. Oh God of gods, oh King of kings, incline your ear, O Lord, and hear the cry of my people whose end is near. The King knelt down, the King, he fell in fear, and with all of him he bowed, as all of us we peer. And in his tears we heard him scream, O God of gods, O King of kings, incline your ear, O Lord, and hear the cry of my people whose end is near. And I, their King, can save them not, for I am only man if they forgot. But I remember this, and also their God, so incline your ear, O Lord, and hear the enemy waves its victory. Oh, hear them laughing and them mocking me. Surrounded I am as he stands tall in tears. I am the collection of all your failures and fears. Your hope is vain, the rest all failed. Why even try to surrender his name? Oh God of
Welcome back, and we continue our talk about the gut and bowel health and the colon diseases. We are very happy to have Dr. Daniel Kozman and Dr. Simon Gali with us. Actually, we have lots of questions about this very important topic. In recent years, there has been a lot of coverage about the gut and gut health and gut bacteria and how it's important, this one. Why is gut health important at the moment?
Yeah, thanks, Maggie. So I think we've covered a little bit of this at the start, that obviously the gut is crucial for absorbing nutrients and for our, to have energy and for our bodily functions. But we've learnt so much more about this in the last 15, 20 years, that our gut is filled with millions of different bacteria and viruses and fungus. We have probably 100 trillion cells of different organisms within our intestine. And so, in fact, if you look at all the cells in the gut, it's 10 times more cells in the gut than there is in the rest of your body. Okay. And what we learn is not just important for nutrition and absorbing nutrients, but for lots of other things, from developing a good immune system, and there's been associations with every other bodily system, whether it's your metabolism and the risk of diabetes, of heart disease, even anxiety, depression, asthma. All of these things have been related some way to gut bacteria. Now, there's still a lot of research going into that, but the more and more we learn, we're thinking about the gut more being like a second brain, is the common analogy. And so the different combinations of these bacteria seem to have important functions, and we know the gut is really the first site, or one of the first sites, that's exposed to the external world. Actually, even before that, even when the baby's inside the mother's womb, it first starts to be exposed to different bacteria, and that develops at the time of delivery, and then particularly in the first 7 years of life. And changes in gut bacteria have been associated with a number of different diseases later in life. And so one of the diseases I work sort of most of my time with is with people who have inflammatory bowel disease, so Crohn's disease and ulcerative colitis, these autoimmune conditions. And so you may hear of people talking about, the importance of having a normal vaginal delivery versus having caesarean sections, having breastfeeding compared to bottle feeding. It's all about, and the other important one, I guess, is antibiotics. So using antibiotics in kids, particularly that first 7 years of life. Yeah. That first 7 years we're learning is really quite critical in developing what does the gut flora or the gut bacteria look like, a bit like having a garden. You want to have a nice variety of grass and flowers in your garden. You don't want it to be, one or the other. And having that good balance depends on a lot of factors early in life. And that balance, or those changes, also change the risk of diseases from obesity, to diabetes, to other gut disorders. And a lot of treatments are being looked at and researched to target the bacteria in the gut specifically. And so this is a huge area of interest for the general population, for researchers, doctors. I must get asked about this at least 5 or 6 times a day, by patients. So lots of reasons why our gut health is important and the gut bacteria is important.
Yeah, Dr. Daniel, if you want to add, and I need to know your opinion about as well the gut bacteria and how it's important. What happens if the balance is not right, or it's an upset bacteria or bowel?
Well, I would say I get asked about this a lot as well, and there's a lot of the question I usually get asked is, what do you think about taking probiotics? And I think the problem we have at the moment is that we don't have enough evidence to really justify people taking these medications, which can be really expensive. And so people take a lot of supplements, they take a lot of different tablets that you buy over the counter. But we don't really have any proof that's going to make any difference. And a lot of the effects that we have from these, especially these probiotics, is, I guess, is a bit of a placebo effect. So we usually encourage people, rather than taking things from the pharmacy, to try and focus more on their lifestyle and their diet. But we were talking a bit before about meats and processed meats versus fibre. And fibre is something that people kind of neglect. So they'll say that, oh, I eat a lot of fruit and vegetables, but when you really ask how much do you eat, it's not that much. And we need fibre to keep water in our stools so that the stools aren't so hard, so our bowel doesn't have to work so hard to pass it. Now, we know that if you have a higher fibre diet, as well as drink a good amount of water, then your risk of things like diverticular disease, which are little pockets that can pop out of the bowel and give us diverticulitis, or they can perforate and make you really sick, or they can bleed, that reduces. The risk of bowel cancer obviously reduces a bit. But then all the other things like fissures and hemorrhoids and all the problems that we see day in, day out, they also will get better. So while there's a lot of discussion at the moment now about bacteria, we're still learning more about this. But right now, I think as just an average person, what we should really focus on is what are we eating every day?
Yeah,
is it healthy? And are we drinking enough water? And are we being physically active? Like all of these things are really, really important, not just for the gut, but for our general health as well.
Okay.
And I guess these things are kind of linked as well. I mean, if we look at what makes the biggest difference to the type of bacteria that you've got, it's what you eat.
Yeah, the
And it's
lifestyle.
So fibre, for example, we refer to as a form of a prebiotic, which means you're giving a nutrient that will promote different bacteria. And so your diet and your food has a big impact. And what you're doing with a probiotic is actually just physically giving a type of bacteria. So most people probably don't need any probiotics. Look, but there are some cases where it probably is justified. If you're having to take antibiotics for another reason, it could be an argument to be on a probiotic to try and keep the balance and prevent secondary infections from taking antibiotics. And in some cases, patients who have irritable bowel syndrome, which if we have time we'll talk about as well, certain strains of probiotics may be helpful. One of the issues, I guess, with the research in this area, that there are so many different products, and the research is being done into one product that has 10 different doses of different bacteria, and it's not an easy area to understand the research, but there are some strains of probiotics, particularly lactobacillus type, that probably are useful in patients with IBS. Certainly, most patients who come to us have already been on them anyway, so they've already tried probiotics. So by the time they come to us, it hasn't worked.
Yeah, because many people maybe experience bloating and constipation and skin. Maybe it's very, very common between many people, which is often put down to irritable bowel syndrome that you said that. So what is IBS? We need to explain it more, and many people doesn't know what's about it and how can it be treated and managed.
Yeah. So irritable bowel syndrome is probably, I guess, one of the commonest conditions that affect the gut and people who present to their doctors. I guess other words you may hear about is sort of the nervous gut, or in Arabic, القولون العصبي.
Yeah.
So these are very common conditions, but the trick is that the symptoms, are not very specific, and that, like you said, some people may have some belly upset, bloating. One type of IBS presents with diarrhea, so going to the toilet more often or having loose bowel movements, and we call that IBS diarrhea or IBSD, or some people present with harder stools or less frequent bowel movements, and we call that IBS constipation, and sometimes it's a mix of both conditions. This is, but I guess the point I wanted to make before is that because the symptoms are sometimes quite vague, you can't assume that it's irritable bowel syndrome. Okay. And so it's important to still discuss it with your GP and to be sure that that's what it is, and whether any further tests need to be done to exclude other conditions, because there are a lot of other conditions that can present with the same symptoms. So food allergies or celiac disease, which is gluten sensitivity, inflammatory diseases of the bowel, and colon cancer. So all of these could mimic IBS. But once you've seen your doctor and you know you've had some basic tests, then you can be confident that it is irritable bowel syndrome and not anything else. And so usually the test would be a blood test and maybe a fecal test, sometimes colonoscopy. But what it actually is, sorry, to come back to the original question, it's a problem of how the bowel's working. Okay, so the bowel is either overactive and it pushes things through too quickly and it spasms and it's all very sensitive, or it's too lazy, okay, and doesn't and moves through. But you look at the bowel and it looks normal. So you put a camera inside, it looks normal. If you took part of the bowel out and looked under the microscope, it looks normal. It's a problem of how it works. It's not a dangerous condition. It's not going to cause cancer. It's not going to cause damage to the bowel. It affects your quality of life, but it's not dangerous.
Okay. I've got one of the related questions that's been sent on the lounge through Slido. Dr. Daniel, if I have IBS, does that may cause a bad effect on my colon? This is all of it.
Yeah, no, as Simon was just saying, that it doesn't have any lasting effects, or it doesn't lead to any dangerous conditions. Often what we see, or what I've seen, is patients who come in with these symptoms, and the most common is bloating. That is by far the most common symptom that they have, and it's usually related to times in their life where they're under a lot of stress, either be physical stress or mental stress. That tends to trigger these symptoms. But then what happens is they get these symptoms in their abdomen, they worry about it, and the more you worry about it, the more you'll convince yourself that you have cancer. That's always happens, right? And so what happens is you stress more, your symptoms get worse, and you end up in this spiral. So really what we one of the best things that we can do is we exclude everything that's serious. So there's no blood test for IBS. There's no thing that we see on a colonoscopy or anything for IBS. It's what we call a diagnosis of exclusion. We've excluded everything else. We've excluded food allergies, infections, inflammatory bowel disease, cancers, all the things that are really serious. And so we say, well, look, this is what you have. You have IBS. And then we emphasize you take confidence from the fact that we've looked long and hard for something that's going to cause you harm and we haven't found anything. So when you get these symptoms, it's usually because your boss is being mean to you or your husband's giving you a hard time, but it's not because you're dying, know. And so, no, it's not going to affect the colon. It's not going to cause any long-term effect. It doesn't lead to cancer. It doesn't lead to any serious problems. It just impacts on your quality of life because you worry about it. So we try and tell people not to worry about it.
So no cure for it or no treatment?
Yeah,
for
you don't
this
worry.
life?
If you don't worry, it'll go away.
But I guess we often get the response then that, this is a bit of a cop-out, diagnosis. You couldn't find anything else, so you've just labelled it, as IBS. But that's not true. I mean, it is a real, it is a real condition and it is, there are treatments. The problem is that there's not one treatment that works for everybody, okay? And it's sort of, it's something that needs to be assessed and worked out. But, when patients with IBS are studied, there are very, in the setting of research, a number of fancy tests are done in the research setting to show that people with IBS have very sensitive bowels. And so, for example, they'll try and inflate balloons in the colon and see at what level they start to feel pain. And people with IBS feel pain at a much lower level, than people that don't have IBS. So there's definite issues, in terms of the nerves supplying the gut being very sensitive, because we know that our gut has a very rich nerve supply that's connected to our spinal cord, connected to our brain, which is why Daniel's talking about, I guess, the effects of, stress and anxiety certainly plays a role. But the other important factors we know with IBS is diet. And then I guess the third aspect, which is where all the interest and it's in fashion at the moment, is the field of gut bacteria and gut microbiome. But, I spend a lot of my time treating patients, with IBS, and it depends a little bit on what their predominant symptom is, whether it's more on the diarrhea side or whether it's more on the constipation or a bit of both. If it's constipation, then you treat the constipation. And we spoke about fibre supplementation or with different types of laxatives. If it's bloating without constipation, then there are simple over-the-counter remedies from the chemist. So herbal things like, iberogast can help. Some people, peppermint oil capsules can help spasm, of the bowel. And then there are formal diets that maybe people may read about and recommended. So one is called the low FODMAP diet, which cuts out different types of sugars from your diet. Now, these are predominantly, fruits and vegetables, and it's a nightmare for any Coptic person fasting. Okay, because, a lot of these are carbohydrates, the cabbages, the lentils.
Yeah, all these,
so a lot of the vegetables, can, make you prone to bloating. Having said that, they're also, very healthy foods.
Yeah.
And some people will use antibiotics, so not just probiotics, but in some people without constipation will use a type of antibiotic that's been more effective. And some people with very sensitive pain will sometimes use medication to reduce reduce the pain associated with it. So that's sort of the three main areas: looking at the nervous system, looking at diet, and whether we can manipulate gut bacteria.
There is a question here that if constipation causes lower back pain, is that a concern? It has related to that? Dr. Diane, do you want to answer?
So I guess with just talking about constipation overall, there are two main types of constipation that we see. There is people who are developing constipation because they have something mechanically blocking their bowel. Obviously, it's like something like a cancer growing in there, or a narrowing from repeated infections like diverticulitis, and that's a mechanical cause of constipation. By far and away, the most common reason we see people with constipation is because of functional problems, the way the bowel works. And there are two main classifications there. There's what's called slow transit constipation. And remember I was saying to you that some patients go to the toilet every week or once a month or so. And when we look at those patients, when you look at their bowel under the microscope, they have fewer receptors for the nerves, so their colon is lazy, so it doesn't get as much stimulation from the nervous system to contract, and so it goes slower. So that's we call that slow transit constipation. Things go through the bowel slowly, and there's a specific test we can do for that, and we usually will treat patients with a combination of laxatives in that situation to try and speed up the gut a little bit. The other type of constipation, which is functional, which is very common, which we see especially in women as they get further away from menopause. Because as you get further away from menopause, the estrogen levels are low, the muscles tend to thin, and we see all the organs in the pelvis, they prolapse, they fall in on themselves as the muscle sags. And so what ends up happening is the bowel, or the rectum, falls in on itself, and you get like a valve. So anything that gets caught above that, as you strain, that valve gets stronger and stronger, and this stuff can't come out. And so what people do is they go, I push and push and push, it just doesn't come out. I get off the toilet, and half an hour later I have to go back to the toilet again. As the muscle relaxes, it comes down, they have to go back. So that type of constipation can lead to lower back pain, but lower back pain is really common. So not everybody who has lower back pain has that problem. So, usually we try and manage both those situations as best we can without an operation. But in rare occasions, we do have to do certain investigations, and we do need to try and do some sort of prolapse operation to rectify that. But as I said, that's more common in women as they get older, as they get further away from menopause, as they start to develop prolapse symptoms.
Okay.
We'd see as well, women have had hysterectomies to remove their uterus, and if they've had difficult deliveries earlier in life, so big babies, or having tears during delivery, or forceps, they're the other things that sort of cause a problem down the track.
Okay. I've got another question. Said, what if I have blood in my urine, and sometimes when I vomit, what should I do, and which blood test should I do? I'm not sure it's related, but it's okay. So what's a blood test should I do if he has blood in in my urine, and sometimes when I vomit as well.
I think if you have blood in your urine and vomiting, you should probably see your doctor rather than having a blood test. I don't think there is a blood test. He really should have his urine checked and to try and work out why he's got blood in his
You
urine.
need to go to the doctor first and
I
see
would say
what's
so, yeah.
further
Yeah.
investigation for it.
And I guess there's kind of, there's separate issues there in terms of the investigations that you would have blood in your urine, you'd investigate that as an outpatient with your doctor, but, if you're vomiting blood, and obviously that's a big,
It's very,
that's a variation in
very
what that
good.
might mean. But if you're having clear blood in your vomit repeated, most people should really go to the hospital if that's happened all of a sudden.
Many people talk about the detox way. So detox, and we see all the social media speak about the detox. How can you clean your colon or your bowel? It's many recipes and many drinks for the detox and the over-the-counter as well. Just I want to know your opinion about it, and if it's good or bad, or what's a healthy way and save our colon.
I guess we've got to ask ourselves what's the reason to look at this. Is it somebody who has symptoms of irritable bowel syndrome, like what we've been talking about, and want to look at a way for treating that, or is it you're just wanting to improve your gut health somehow? But really, in terms of gut detoxes or lavages, or people having vitamin C infusions, the more you look on the internet, the more you'll find of wacky ways of doing things. There's really no need for people to have a gut detox or to go on to water diets, to have bowel cleansers. There's really no good medical reason why you'd need to do that. I think the take-home message from tonight in terms of maintaining good gut health just comes down to good lifestyle. So a good varied diet, being physically active, having enough fluid in your diet. I think as a Western society in general, we've moved too far towards having a very meat and fat-heavy diet with a lot of processed food with less fibre and fluid. And I think, if we looked a bit more at a Mediterranean diet, which we should be, then, you've got more fruits, more vegetables, fish rather than, red meat, then that's probably the best gut detox, to have. Yeah.
So I think we cover everything at the moment. So, but last question for us: how can we keep our gut health and function and to be improved? Or so how can you do it, Dr. Daniel? Or it's up to you.
Well, look, I think that kind of summarises everything we've been talking about today. But yeah, look, I think really it just comes down to a good lifestyle. You shouldn't really be needing to spend money at naturopaths or chemists taking lots of supplements. All the nutrients you should be able to get from whole foods. There are exceptions and conditions where you might need some supplements, but in 2020, having a high fibre diet with less processed food and being physically active is really all you should need to do to maintain good gut health. And I guess also being mindful, because I know just in the general, there is an overuse of antibiotics, and I think that's another thing to be mindful of. That sure, antibiotics can be life-saving, but some of that just overused, and if you don't really need antibiotics for a cold or a flu. So that has a big impact on gut health. So,
So Dr. Daniel, any recommendation for diet recommendation or a healthy lifestyle to?
So the most common discussion I have with my patients is fluid intake, because drinking water is hard and people often forget. And people say, I drink a lot of water, and when I say, how much do you drink? They'll say 1 litre a day. And we should really be having 2 to 3 litres of water a day. And as Simon was saying, a diet that's high in fibre and that's well portion controlled. Like we should also be mindful of how much we're eating. And so, like if we try and live our lives as healthy as possible, all of us will be healthy, including the colon. You know, there's no specific diet just for the colon. So I think it's really about trying to have more fruit and vegetables and less of the sweets and the meats and all that sort of thing, and really just being mindful each day, asking yourself, you know, a couple of times a day, have I drunk enough water? Have I drank enough water? I know the phones now will nag you, or your watch will nag you to drink it. Maybe we should listen to our technology and drink water more.
Yeah, what about the exercise and walking and simple exercise like walking? Is this can help?
Definitely exercise helps bowel function. In fact, I remember probably, I think it was about 10 or 15 years ago, the Italians did this study. This was an interesting study. They took a soccer team of young, healthy men, and half the soccer team they made lie in bed for a week, and the other half they let go to training and live normally when we used to be allowed to live normally. And what they found is the ones that laid in bed, their bowel function was much slower compared to what they were like before. So physical activity definitely helps bowel function. And so there are lots of good reasons to exercise, and bowel function is one of them.
Thank you so much, Dr. Daniel. Thank you so much, Dr. Simon Sakely, for all the information that you have given us tonight. Thank you so much.
Thank you for having us.
Thank you.
Thank you. Thank you, everyone, and we hope you benefit from this episode. Thank you, and see you next episode from The Lounge.